Hey everybody, welcome back. I hope you did great on that first exam over the first unit. And now we're shifting gears. We're switching over from generalities about the profession of athletic training into the specifics of body part injuries associated with those body parts, evaluation, rehab, all those things. Probably the more exciting portion of the course if you are like I was when I was taking a course very similar to this. So we're basically going to start from the ground and work our way up. And the reason I do that is oftentimes when I'm teaching a course like this, students are also doing clinical experiences and they are working with athletes day in and day out. And I used to go in kind of head to toe order, but a student once asked me, I said, we deal with ankle and foot injuries a lot more than we deal with shoulder or elbow or wrist and hand. It would make more sense for us to get the lower extremity information sooner. And that made sense. So that's the reason for us starting with the foot and working our way up. So our task for this week is to look at the foot. Oftentimes I do this as foot, ankle, lower leg, but we had enough time that I could do these as separate units. So hope you enjoy this section on just the foot. So we're going to look at the anatomy first. We'll take a look at some gait basics, and then, as we will do for every body part, injury prevention, injury assessment, injury recognition and management, and then rehab. All right, now the foot consists of 26 total bones, and we start by looking at the toes, the phalanges. There is a proximal, intermediate, and distal phalanx in rays 2, 3, 4, and 5. The great toe, however, just has 2. There's no intermediate phalange in ray 1 in the great toe. So we've got 14 phalanges. We've got 5 metatarsals, 7 tarsals that form in the case of the talus, it forms part of the ankle. And then we also have 2 small sesamoid bones. A sesamoid is basically like an anatomical pulley. It increases the leverage that a muscle has. It's not really considered part of that 26, but they are there. And on a rare occasion, we may have an injury there to a sesamoid. So skeletally, we know that that's what the foot consists of. Those bones form some functional structures that we need to be aware of. The arches, namely, in particular, this medial longitudinal arch can determine to what extent an athlete's able to shock absorb when they run, how their footwear is going to fit, that kind of thing. But it's not the only arch. We also, the foot has this, if we look down through the toes, we have 2 arches of note there, the metatarsal and the transverse arch. That large medial longitudinal arch is pretty obvious to see. We can see the lateral longitudinal arch in the skeleton pretty easily, but when we get soft tissue here, it just looks flat. Now the purpose of those arches is kind of a built-in spring-loaded shock absorber. So it does absorb shock, but it also serves as a means through which the foot can interact with the playing surface, or wherever we are, whether we're mountain climbing or whether we're running on a football field, whatever. It allows the foot to have this shape such that it can adapt and conform to whatever that terrain is. Now, in years past, we used to stick feet in shoes that had a big clunky one-piece sole, oftentimes fitted with shock absorbers of some sort, whether it was air or gel or sorbethane or any other number of manufactured products. And in recent years, we've actually recognized the importance of a more minimalistic shoe design, so that that foot is free to move. Even though we're wearing footwear to protect the soft tissue, the skeletal structures and the functional anatomy structures are free to do what they were intended to do. So if you've got an athlete who's transitioning from those more traditional shoes into those free motion shoes, then sometimes they'll be sore. Their muscles are working in ways, and their skeletal anatomy is moving in ways that it's not used to moving. So that can take some time to adapt to. Ligamentous anatomy in the foot. We'll spend a lot of time talking about ligamentous anatomy in the ankle, but honestly, ligamentous anatomy in the foot is largely an academic pursuit. We don't necessarily need to identify the specific ligament that's injured if we've got a foot sprain, because we know that each of those tarsal bones are kind of tethered together with ligaments, and if we've got too much movement in, say, the cuboid here, there are a number of ligaments that connect it to the adjacent bones that are all involved, and we're going to treat it the same regardless of which ligament it is that's injured, with a few exceptions. On the plantar surface, we have our long plantar ligament that helps form that arch. It can be involved if we've got heel spur, other types of conditions that involve the sole of the foot. Okay, the movements of the foot, a little different than a lot of body parts. Typically we talk about flexion and extension in most every other body part. The foot's a little bit different in that we don't call it flexion and extension. We call it dorsiflexion, toes to the nose, plantar flexion, pressing down on the gas pedal. Our foot is also free to move in the frontal plane, in inversion, rolling the arch toward the midline, and eversion, turning the arch away from the midline. At the toes, we also have flexion and extension, and we can also deduct and abduct the toes, so that we can grasp objects or interact with the playing surface, move in our shoes, whatever. Now, normal gait consists of two phases. We've got a stance phase and a swing phase, and what we see here is based on this patient's left foot. So we've got initial contact or heel strike. Loading response phase is when her body weight shifts so that the center of mass is actually over the foot instead of behind it. Mid stance, we see it's right over the top. Terminal phase, some people will refer to the pre-swing as toe off. So in the terminal stance, it's kind of the last instant at which the foot is flat on the surface. As we get to pre-swing, the heel comes up off the floor, and eventually the toe comes off, and then we swing that foot through, and the whole process starts again. Okay, so while this left foot is in stance phase, right foot is in stance phase, we see the left foot is in swing phase. So they just kind of alternate back and forth. Now, stance phase accounts for the majority of the gait cycle, so we're weight bearing through that time. The swing phase is the period of non-weight bearing, and the forces move through the foot. When we initially heel strike and get to mid stance, we see that the foot is it's relatively pliable, and it will deform to conform to the playing surface, and that's what we want. We want force absorption. That's going to prevent soreness, going to prevent forces from coming up through the lower extremity. Once we get past this mid stance phase, our foot becomes more rigid as we start to transition from a shock absorber to a propulsive mechanism. If we've got a weak, floppy foot, then we're not going to have optimal propulsion. So we see that the foot changes from kind of a shock absorber to more of an engine, and because of that need to switch, it is a versatile piece of anatomy that serves a number of very different functions depending on how the body's using it. Okay, so running and walking gait have the same components. Really the only difference here is that we've got a period of a flight phase or a period of no support phase, so that that landing, that loading, and that mid stance occur more rapidly. So initially, as we said, that foot serves as a shock absorber when the heel initially strikes the surface, and then it adapts. At toe off, it's a rigid lever that gives us that propulsive force. We know that depending on how we are running, that our gait changes a little bit. So if we're distance running, more of an energy conservation method, sub-maximal speed, then we're going to use a very similar pattern of shock absorption and propulsion. On the other hand, a sprinter, sprinting is actually highly inefficient in terms of energy consumption. And so the sprinter tends to run on their toes as opposed to striking at the heel, because striking at the heel actually introduces a braking force to a certain extent. And that's the difference between winning and losing. So a sprinter tends to be out over their toes a little bit more, and all of their propulsive force is directed away from them back, so that it is not providing a braking force, but rather a propulsive force. Okay, we also know that the lower extremity moves as a unit. It's not just the foot that can form. So at initial contact, the tibia actually externally rotates slightly, and the tala, the subtalar joint, supinates. And that's what's going to allow the foot to engage that running surface or walking surface. As that pronation occurs at the subtalar joint, the tibia actually internally rotate, and this allows the foot to be that shock absorber. So we see that the lower legs actually kind of direct this transition from a shock absorber into something better intended to be a lever. Okay, so we know that the foot it's highly versatile. It has to serve a number of very different functions. So preventing foot injuries is sometimes a challenge. It is a vulnerable area. It's likely to get stepped on. It's quite frequent that we're going to encounter forces here, so overuse injuries are common. So the balance here between acute injuries and traumatic injuries is pretty similar. One's not necessarily more likely than the other. It just kind of depends on the athlete, depends on the sport. So the best way to prevent injuries is to select proper footwear, fix any biomechanical issues or structural deficiencies that we see that are problematic, and then also pay attention to hygiene, which doesn't make sense on the surface. You would think, well, are stinky feet going to lead to injury? Well, foot hygiene involves more than just cleanliness. Nail health, taking care of blisters, properly fitted footwear, making sure that we try to keep the skin as dry as possible. So there's a lot of things here that can help keep the feet healthy. So one of the keys here is to select proper footwear. And we know there are countless options available, but more often than not, the athlete tends to pick their shoe based on style more than function. So we want to make sure that the footwear is appropriate for the structural variation. Some people have a very narrow foot, some people have a wide foot, some people have a high arch, some people have a low arch. So instead of picking our shoe based on what looks the best or what style we like the best, we really should fit the shoe to the patient. Okay? If a patient is a pronator, then a rigid shoe is recommended. If they are a supinator, then a more flexible piece of footwear is recommended because it's got increased cushioning. So a supinator has kind of a high arch, and oftentimes they'll have kind of a rigid, unyielding foot. It's more lever-like all the time. Whereas a pronator tends to have a flatter foot, and it's acting more like a shock absorber. So varying that foot, varying the type of shoe, can help make up for the deficiency in that person's particular foot anatomy. And a lot of that is just that. It's It's not necessarily that we can change the anatomy of our foot. It's not due to training, it's just genetic variation, and we have to deal with what we've been given. Okay, what's called a slip-lasted shoe, we see here, is very flexible, so it will actually bend all the way around where it's sewn into the shoe, and then it's also flexible in the center. A board-lasted shoe, on the other hand, is one piece and it's sewn in. So the only way you can tell, it's not going to say it anywhere on the box that it's slip-lasted or board-lasted or combo-lasted. We have to basically pull the liner, the sock liner, up and take a look. That's the only way you can tell. A combo-lasted shoe has a slip last in the front and a board last in the back, so that we get more stability in the back and mobility in the front. The last of the shoe is basically the sole. The shape of it can also influence how we run. Okay, so if we see this relatively linear arrangement between the heel and the toe, that's a straight-lasted shoe. Whereas with this shoe, you can see how it kind of curves around, and maybe that red line doesn't follow it exactly, but we get the idea here. So if a patient's having foot problems, then it's probably worth investigating. Okay, and the way we can tell is to look at the wear pattern on their shoe. Now, we can't tell that on a new shoe, but if they've worn it for a couple of weeks and they've been running in it, we may see that they've got heavy wear on the outside, and that may tell us that a curve-lasted shoe may be better for them. Okay. Other things we look at, where is the last scored, or where is it intended to bend? There may be notches or grooves that kind of tell the shoe where it should be most flexible, if you will. The way they lace up, how we lace them, all those things can have an impact on how that shoe fits and how that shoe performs. Now, most shoes are designed for an average patient, quote-unquote average patient, in terms of arch height, medial longitudinal arch namely. If a patient has a particularly low arch and they're a pronator, then that shoe is going to feel uncomfortable because it's attempting to push up on a portion of the foot that's not there. For a patient that has a really high arch, they're going to have an area of slop, if you will. It's going to be too loose in that region. So for patients like that have poorly fitting shoes based on the sock liner that's included, we can try arch supports. Sometimes running shoes actually come with those so that you can add a little extra if you're a supinator. Or the alternative is an orthotic. An orthotic is a custom fit bed that is designed to conform to the sole of a particular individual's foot so that it fits better. Okay, there are over-the-counter versions available. Some are, Dr. Scholl's, things like that really don't fit any better or worse than the factory ones that came in the shoe itself. Others are semi-moldable. You can toss them in the oven for a couple of minutes at 200 degrees, slip them in your shoe, step in, and they'll conform to your foot. You can find these at sporting goods stores. They work okay, but kind of the gold standard is a custom fit orthotic where you go to a podiatrist, they'll measure your feet, have you step in, make molds of your feet, and then they'll make you a custom liner designed just for you. Now, we said hygiene was also an important way to prevent foot injuries. Keeping the toenails trimmed correctly is highly important here. Ingrown nails are debilitating, they're terribly painful, and they can certainly derail training for a week or more, depending on the severity. Lots of times distance runners will get initially blisters, but eventually calluses, and these calluses can be so big that they actually alter the mechanics of the foot, so those need to be shaved down from time to time. Sock fitment is important, so they should fit correctly. They shouldn't slide down Lots of athletes like the no-show socks, and they'll slide down, they won't stay up. That can cause problems. And then keeping the feet dry is important, just for overall skin health, because we know that if the skin stays damp, then it's more likely to blister, and we want to prevent that if we can. All right, so last time we talked about the hops process, and we're going to apply that specifically to the foot. So our history questions are going to involve some generic history questions here. You know, how did the injury occur? Where's your pain? Those kinds of things like we talked about last time. But specifically to the foot, we're going to look at a number of history questions that really wouldn't make sense for any other body part. Okay, do you have pain in your heel? Pain more out in the toes? Pain in the arches? Have you changed training surfaces recently? Have you changed footwear recently? Does specific footwear increase or decrease your pain? Those are all valuable clues that could help us determine what the source of their pain really is. For foot observations, we want to see, do they favor one side or the other? Are they walking with a limp? Are they unable to bear weight? We want to see if their foot changes color with weight bearing. That might indicate a vascular insufficiency. So the only way to do that is have them walk around a few times barefooted. Okay. Pes planus, a flat foot. Pes cavus, a high arch. We look at their arch while they're walking. We don't just look at their arch off the edge of the table. We want to see them in weight bearing. Foot alignment is one toe pointed forward with another pointed out. Are there any structural deformities? In particular, we want to see, are there differences from left to right. Okay, so we'll look at this in non-weight bearing off the end of the table, and we'll also look at this in weight bearing. Okay, we want to use what's called subtalar neutral, where we basically see the calf, the Achilles tendon, and the calcaneus all in this neutral alignment. And what we can see here is this patient's foot, even though their calcaneus is in neutral, their subtalar joint is in neutral, their foot is not. Okay, so that could potentially lead to some biomechanical issues. Okay. So as we already said, shoe wear patterns are important to look at. So they've taken their shoes off, they're walking around barefooted, and now we want to take a look at those shoes. Okay, we flip them around and look at them. If they are an overpronator, their foot is flattening out too much, they tend to wear their shoe out under the second metatarsal, basically right in the middle. Oftentimes people perceive wear on the outside edge of the heel as being from overpronating, and that's not necessarily the case. Okay, they may actually invert. So remember we said inversion is the soles of the foot turning toward midline. Their anterior tibialis is actually pulling that foot up into inversion, and they're striking on that outside border as they're heel striking. Okay. Wear on the lateral edge, the lateral border of the shoe. Let me grab one here. Okay. So we got wear on this outer border. That might indicate that they are supinating too much. So they are like we said, if it's tight anterior tibialis, it's going to be this heel lateral border. If it's supination in general, it's the entire lateral border. Okay, so we want to look at the heel counter, the forefoot area. These shoes aren't very old, so my wear pattern here is relatively equal. If anything, maybe a little extra wear on the lateral border. I haven't run in these much. These are kind of new. Okay, we also want to, so we do our history, we do our observation, and then we move to palpation. And we'll do palpation kind of in rounds. We'll do bony palpations first, and then soft tissue next. So it's important to just kind of walk our way around the entire foot And when we are palpating, we're looking for a couple of things. First of all, do they have provocable tenderness? If I poke on a certain spot, does it cause them to light up or flinch or otherwise have pain? I'm also looking for obvious signs of deformity and differences from left to right. For soft tissue, I'm basically going to palpate around. I'm also still getting some skeletal palpation here, but in particular I'm looking at muscular insertions, tendons, ligamentous anatomy, and same thing, I'm looking for obvious deformity, provocable tenderness. Okay. Further soft tissue that I look for here, I'm thorough in going through. So what I'd advise you to do is look in the textbook. There's several good anatomy diagrams, and just be familiar with the anatomy listed there. Some of that may appear on an exam. You may need to be able to identify some of the more prominent muscular or skeletal anatomy structures at any of the body parts that we talk about. The last palpation we do is for pulses. Okay, we want to make sure that we've got adequate circulation in the foot. So here we're going to do the posterior tib and the dorsalis pedis arteries. Okay, so we can usually feel the posterior tib behind the medial malleolus, right along the Achilles tendon. And the dorsalis pedis, easiest way to do that one. So imagine this is my patient's foot. I'm going to stick my thumb right in their arch, and I'm going to wrap my fingers around the anterior aspect of their foot, and I should be able to feel that between their extensor digitorum and their hallucis longus tendon. So somewhere between the third and first ray is where my finger needs to fall so that I can feel that dorsalis pedis pulse. So we've done history, we've done observation, we've done palpation. Now we move to special tests. Okay, and there are a lot. I won't pretend to tell you that what we're going to cover here is even the tip of the iceberg in terms of special tests that can be done for a particular body part. But some of the more common ones that you may see if you're doing hours in a PT clinic or working with athletic trainers, you may see them use some of these tests as part of their foot assessment. First thing I do is just have them move around, wiggle their toes, looking for normal range of motion, looking for normal motor function. Okay. From there, I can use what's called a Tinel sign, and this isn't unique to the foot. We can use a Tinel sign in a lot of different areas. Here, I'm going to tap over the posterior tibial nerve to see if they've got tingling that shoots distal to the area. Any Tinel sign is usually intended to see if they've got some hyperactivity in the nervous system structure, okay, or an impingement of some sort. So for instance, in the elbow, you've probably hit your funny bone before. I can do a Tinel sign at the ulnar nerve, and as I tap there, I'll feel that numbness, that bright, sharp pain shoot down into my hand if I have a hypersensitivity here. Same thing here, but I'm using a posterior tibial nerve instead of the ulnar nerve. Okay, Morton's test, some people call this a squeeze test, basically just grasping the foot and applying a compression that's going to kind of further increase that metatarsal arch. A positive test here is usually pain due to compression. That may tell me that they've got a neuroma or a metatarsalgia, which is just pain in the metatarsals. Sometimes you'll have a patient with a stress fracture who could also have a sensation of pain with a Morton's test. Now, I probably need to back up a little bit. When we're doing special tests, we're really looking for one of three things. We're looking for pain provocation, in which case I'm not really able to have 100% certainty that what the patient's telling me is actually what's occurring. So a pain provocation test would be something like a Tinel sign or a Morton's test. Now, if the patient were unconscious, this test is useless to do. Okay, so I have to see their reaction in order to determine whether or not it's positive. A second thing I can look for is an instability or a stability test. And here I can do this when they're unconscious on a surgical table if I want to. Okay, here I'm actually testing to see if there's ligamentous stability. So pain provocation, stability, and then my last one would just be motor function or muscular contraction. Okay, and again, they could. This one's a little different because they could try to fake this one. They can't fake an instability test. If they've got laxity in a joint, then I'm going to be able to tell that if my testing is good and I'm doing things correctly. With a pain provocation test, they could it's entirely dependent on what the patient tells me. With a muscular activity test, it's dependent on them giving me full effort. Okay. A neurological assessment at the foot basically involves doing sensory testing. I just want to check from one side to the other if sensation is the same, motor function is the same, wiggle their toes, and then reflexes. Okay, so I check their skin sensation bilaterally to see if there's any difference there, and then I can also you'll probably see when you're observing, you'll see your clinician, your preceptor, use a reflex hammer to test deep tendon reflexes. So that is a very scaled down version of what a foot assessment looks like. Now chances are if you're observing one, you're going to see a lot more than that, but those are just some basics. When it comes to injuries, we kind of divide these into where on the foot they're occurring. So your textbook does a good job of kind of grouping these together, kind of talus or deep on the foot, midfoot, and toes. So foot problems can be associated with improperly fitting footwear, poor hygiene, poor biomechanics. So we have to be aware of what these problems are, how we can identify them, make them better, or prevent them. Okay, so a talar fracture can occur from a severe inversion sprain. Can sometimes even occur due to a direct load. You see this sometimes in automobile accidents, a fall from a height where someone tries to land on their feet. Usually someone with this condition, this will be an acute injury, but this can also occur due to repetitive ankle trauma, where they actually end up with damage to the dome of the talus and the articular cartilage, the joint surfaces start to deteriorate and wear away. Okay, so to manage these, we're going to focus on strengthening the ankle and gaining full range of motion, because that can oftentimes be pretty severely compromised, as you can imagine, because the talus is half the ankle joint. If trying to manage this through rehab doesn't work, then surgical repair may be necessary, and this is a long, slow recovery. So return to play 6 to 8 months post-op. Okay, the calcaneus, we can also injure this one by a jump from a height. So instead of the talus slapping up into the tibia and being injured, instead we've got the calcaneus, which lies below, that may be injured. Okay, we can also have avulsion fractures here. Sometimes we can have a misdiagnosis as a tendonitis of the posterior tib. This could also involve the gastrocsoleus complex. So this will usually present with swelling, pain. They can't bear weight. That's where heel strike occurs. So they'll be real ginger and light on their feet there. They don't want to bear a lot of load there. Usually we won't be able to actually appreciate deformity unless they've got kind of a shattering of that bone. This one would be referred for x-ray. If it's non-displaced, it's in position, we can immobilize them. Usually they're going to put them in a boot, and then we'll do early range of motion when the pain and swelling subsides. Stress fractures at the calcaneus occur because we do heel strike here. This is usually a much different history, so instead of it being a traumatic fall from a height, it's I just ran and I've got heel pain, and the more I run, the worse it hurts. Sometimes it hurts even after I run. Those are going to be consistent with any kind of stress fracture. Calcaneal is going to be, sole of the foot specific. excuse me, they're going to have pain with weight bearing as they progress. As with any stress fracture, they're going to have complaints of pain that follow exercise, and this might not show up on an x-ray. Might need a bone scan for a complete diagnosis. So conservative management here, 2 or 3 weeks of rest, just doing range of motion exercises, and then a gradual reintroduction into activity. We're going to try to keep their cardio conditioning up with some non-weight bearing. Put them in a pool, put them on the arm bike. As they get better, we're going to put them on a lower impact piece of equipment like an elliptical or a stair climber, something like that. And then even as we reintroduce them into running, we might have them start on a rubberized track or running in the grass before we have them running roads again. All right, another injury to the tarsal region could be apophysitis of the calcaneus. And an apophysitis is basically when an attachment point on the muscle becomes irritated and inflamed. So this is a traction injury where the Achilles attaches, and oftentimes the patient just thinks it's Achilles tendonitis, but unfortunately it's more related to the bone than it is to the tendon. So it's really low on the foot. This is usually worse after strenuous activity, and it usually goes away after activity. A heel lift could relieve some stress, much like we would see, and we'll talk about this with the ankle when we talk about Achilles tendon issues, because it does take some of the tension off. Okay, retrocalcaneal bursitis. Retro means behind. Calcaneal refers to the calcaneus, and bursitis refers to an inflammation of the bursa there. So we see this kind of prominent bump, sometimes called a pump bump, because in some individuals, if they wear a female athlete wears a high heel shoe, it may rub right there and cause trauma to this structure. It's not just heels, but it could also be regular shoes if they've got poor padding at the Achilles tendon. This is usually a chronic condition that develops over time. It may take a while for this to reveal, or to resolve rather, but they may end up with a permanent deformity here, an exostosis, which is a calcification. They usually have pain with palpation. This is very superficial, so unlike Sever's disease that we just talked about, that's more deep and bone pain, kind of that dull ache, this is sharp, superficial pain. NSAIDs can help with this. Ultrasound can help with this. But really it's just a question of what's causing it. So if we can minimize compression to this area, it will usually get better pretty quickly. Okay, heel contusion, heel bruise. Here we see an individual, usually they'll either land forcefully from a jump, or sometimes this is called a stone bruise. They'll actually have a rock in their shoe, and it will result in a bruise to the soft tissue of the foot. They will oftentimes have pain at heel strike. This can be really debilitating. It'll heal pretty quickly if we can prevent what triggered it, but if you can't bear weight, then there's not a whole lot you can do. You can't run, you can't cut, you can't jump. So we reduce weight bearing for 24 hours. We can use something like a heel cup, Tully's, or a Dr. Scholl's with a gel cushion insole. And this will usually resolve pretty quickly, but it is really debilitating and can cause some problems for a few days. Unlike a heel bruise that can cause trouble for a few days, tarsal tunnel syndrome can be debilitating and cause problems for weeks or months. Okay, so here there is a tunnel that has a bony floor and then a roof composed of soft tissue, and because of its structure, it is a common site for a nerve entrapment. Okay, so we end up with weakness usually here and pain. They'll usually have pain, paresthesia along the middle part of the foot, the sole of the foot, and as it worsens, usually it will turn into a motor weakness. Okay, they will oftentimes have increased pain at night, and then a positive Tinel sign, like we said, that tapping on that area produces pain that radiates. Oftentimes, conservative management is going to be our first attempt to fix this. If that doesn't help, then surgical correction is necessary. We've already talked a little bit about planus foot. If it's asymptomatic, frankly, if it ain't broke, don't fix it. Kind of that old adage. This is as planus of a foot as you're ever going to see. This is a fallen medial longitudinal arch, but in some patients that's just normal for them. It's not necessarily traumatic, but in the case of a painful planus foot, then we have to deal with it. Okay, they will end up with calcaneal eversion. The navicular will oftentimes kind of bulge out here medially, and then that medial longitudinal arch just goes away. Sometimes that first toe will splay out as a result of this. If this is problematic, then an orthotic is going to be our best line of defense. Pain after activity, ice cup can be beneficial. Gentle stretching to the sole of the foot, arch taping can be helpful, but this is one that's probably not going to go away. We just have to manage it symptomatically. The opposite side of the spectrum, we see a high longitudinal or medial longitudinal arch, and that's referred to as a cavus foot or pes cavus. They are going to be a supinator, and they're going to have poor shock absorption because that high arch isn't allowing that foot to interact with the shoe or with the running surface. Again, if this is asymptomatic, leave it alone. Sometimes you can cause problems by trying to address this, so just kind of keep an eye on it. Orthotics can be used. A lateral wedge can help with this condition, and because of their excessive supination, we want to make sure we stretch the Achilles and the plantar fascia. Now, with a longitudinal arch strain, this isn't necessarily tied to either a planus or a cavus foot. This can happen to any patient regardless of what is normal for them. They'll oftentimes have pain with running and jumping below the posterior tib tendon. They may also have some other soft tissue injury associated with this. Arch taping can be helpful for this. Usually we're going to have them in at least partial weight bearing or non-weight bearing for a time to allow this to recover, but these will usually resolve on their own pretty easily. Plantar fasciitis is another one, pretty common in athletes and non-athletes alike. This could be worsened by a sudden increase in activity, so somebody hasn't exercised much. Their foot can be relatively rigid, and now suddenly it's being moved through a lot of motion and a lot of loading, and it can irritate the tissue on the sole of the foot. So for this one, looking at ways to increase the mobility here is necessary. We might change them from rigid supportive footwear to a more flexible piece of footwear. This could be a result of poor running mechanics. Okay, they're going to have pain over the anterior aspect of the medial heel. Oftentimes their pain is worse in the morning when they're in a non-weight bearing position. Their foot kind of relaxes into this shortened position, and then as soon as they step down, that just kills them in the morning. So increased pain with dorsiflexion. So we treat this in something like a night splint. It keeps the foot from relaxing in the evening, so it keeps it in a stretched position. This is probably the best treatment for this. There are other things we can do as well. Orthotics can be helpful. Arch taping can be helpful. Every once in a while, in really serious cases, a cortisone injection may be necessary here. Alright, in the metatarsal region, so we're kind of working our way out towards the toes. One of the more common fractures we see in the foot is referred to as a Jones fracture. This is a fracture of the base of the fifth metatarsal. We see this oftentimes in patients who are really heavy. This is a common one in an offensive lineman. They also tend to have planus feet. They'll have pain, tenderness. We have to make sure that this is not a perineal avulsion or a tendinous injury, really superficial or really, I guess, proximal here, but distally out into the bone itself. Okay. Management for this really varies. For a long time, the treatment of choice was to stick a screw in the fifth metatarsal and let it heal. The problem with that is this bone bears a lot of load, and those screws have been known to bend or break. A cancellous bone screw has been used, but they're much weaker, so you got to hold them out of activity much longer. We had this done in one of our offensive linemen. He was 330 plus pounds, and he had a stainless steel screw inserted, and within a matter of, I don't know, 2 months, he was having problems again, and we discovered that he had actually bent the screw. So fixation is ideal, but if we don't get fixation, we've got to have immobilization, because we can end up with what's called a non-union, and that's where the two ends of the bone won't heal back together. Bone growth stimulators have been suggested. These have been shown to increase the rate of healing, so that may be something to consider. Other metatarsal fractures can occur other than the fifth, and in the case of a non-traumatic stress fracture, we see that same progression. Just more activity leads to more pain. Less activity decreases pain. As these progress, they hurt all the time. Early on, they just hurt during activity. Later on, they hurt after activity. So, definitive diagnosis for stress fracture is going to be a bone scan, but the first couple of weeks we're not going to be able to see this on an x-ray. It's going to gradually progress from diffuse, just generalized foot pain into a specific spot as it kind of zeroes in. 2 to 4 days of partial weight bearing followed by 2 weeks of rest. Usually these will resolve relatively quickly, and again, orthotics may be necessary, looking at running surface may be necessary, looking at footwear may be necessary. Bunions, we see these out in the toe, so this is basically a prominent first ray with an associated lateral deviation of the phalanges. This leads to a big bony prominence in a narrow part of the shoe, and this can lead to soft tissue issues and mechanical issues. You notice how in this patient the second ray has actually crossed over the first. It's pretty common. They'll end up tender, swollen. The joint itself is being loaded in an unnatural way, so these can be a big problem. Again, had this in another offensive lineman. We injected it, or the physician injected it rather. We tried taping, we tried various insoles, and eventually he had to have a surgical repair done that basically realigned his first ray. So that's referred to as a bunionectomy. Morton's neuroma is a thickening of the nerve sheath, so you see that nerve in yellow here, where it divides, and it's basically being compressed between the rays. So tenderness in this area, we're usually thinking it's either a neuroma or possibly a stress fracture. They can present very similarly. It's pain away from a joint, so we're not suspecting ligamentous involvement. The presentation is going to be very similar, just gradual increase in pain. The history is going to be very, very similar. The question is, what's their pain like? If it's just dull, achy pain, then think more bone. If it's sharp, bright, radiating pain, think neuroma, think neurological. Just like with a stress fracture, pain is going to be relieved with non-weight bearing. Toe hyperextension increases their symptoms here. So we want to rule out that stress fracture first. We can use something like this teardrop pad that helps prevent the bones from compressing the nerve. We may also want to look at the shoe. If the toe box is too narrow, then it's going to lead to that compression, whereas if it's wider, it's going to allow them to stay spread. And if they continue to have problems with this, then surgical excision may be required. Toe sprains, see these often. These usually heal pretty quickly, usually caused by kicking a non-yielding object and spraining the joint. Immediate pain, it's sharp, it hurts, but it doesn't last very long. They may be swollen and discolored for a couple of days. We can buddy tape these together and then start them back to weight bearing as tolerated. Turf toe is a common specific sprain to the toe, and here this is a result of, and the reason for its name is AstroTurf, old school kind of indoor carpet, has a high traction level, so an athlete falling forward, instead of their foot just slipping out as it would in grass, their shoe stays engaged with the playing surface and they end up kind of folded back over themselves. This can be the result of a single trauma. It can be a result of repetitive microtrauma. We'll also see this sometimes. They get stepped on and then they fall forward, so they end up with that same mechanism of injury. We can tape these. We can put an insole in their shoe that limits the amount of extension that they have. Ice and ultrasound can be beneficial here, but really the key is optimal loading. If they keep this aggravated and irritated, this can last all season. If we manage it appropriately right off the bat, usually within the span of a couple of weeks, this will improve. Toe fractures, toe dislocations, this can be from kicking unyielding objects, stubbing the toe, getting stepped on. Fractures are actually quite a bit more common than dislocations in the toes, quite a lot of ligamentous support. We don't reduce dislocations as athletic trainers. Physicians do that. Casting or boot walker, something like that, may be necessary. Lots of times, even with a fracture, buddy taping is going to be at least as effective as anything else. Casting can be problematic. Hallux rigidus, this is basically stiffness in that first ray. They'll end up with bone spurs or other type of ectopic bone growth that results in a loss of range of motion. This is a degenerative process. It's arthritic, where the articular cartilage and the synovium are changing and basically diseased and unhealthy. This loss of range of motion leads to gait compensations. So the foot starts to roll laterally to try to get over that rigid first toe. Forced dorsiflexion causes pain, and they have difficulty walking because of the altered mechanics in the foot. So that lever of the foot, it doesn't change, and it doesn't allow the foot to be as effective of a shock absorber. It's basically locked in as a lever all the time. A stiffer shoe with a large toe box can be helpful here. Orthotics, similar to those that are worn for turf toe. Basically, that joint is rigid, it's hypomobile, and it's not going to get more mobile. And if we stress that joint, it's not going to gain range of motion, but it is going to get irritated. So we want to try to minimize the amount of loading that that the joint's exposed to. So a physician may do what's called an osteotomy to remove whatever those mechanical obstructions are so that they can return to normal. But frequently this is almost more trouble than it's worth, because they may have to be non-weight bearing for 6 weeks plus while allowing that to occur. Subungual hematoma, you see this in the fingernails as well as the toenails. You smash your toe, you get bleeding under the nail, and this pressure buildup is very, very painful. This ultimately will probably result in the loss of this nail. It will grow back. We apply an ice pack to minimize the bleeding when the initial trauma occurs, and we want to relieve that pressure early. If we wait too long, the blood will actually coagulate and it won't come out. In this case, this one's probably too old. If we caught this early, we would drill this nail and the blood would drain so that that pressure buildup wouldn't cause the pain, or so that that pressure build, yeah, so the pressure buildup wouldn't cause an increase in their pain. So that leads us to rehab. Lower extremity, a couple of keys here. Non-weight bearing or reduced weight bearing are going to be our friends. So things like pooled therapy. We use what's called an AlterG, which is a suspended treadmill that unloads the body but still allows the patient to run. Upper body ergometer, which is basically just an arm bike, is another tool that we can use to help maintain cardiovascular fitness while they are recovering. But then just general strengthening and flexibility exercises as allowed are going to be beneficial here. For weight bearing, non-weight bearing means we are on crutches. We're not putting that foot down at all. Limited weight bearing, crutch walking, if they can do that without a limp, then that's going to, again, remember our optimal loading is more important than just rest. So when we can start to get them back bearing some load without making the condition worse, we want to do that. We want to get them back to full weight bearing as soon as tolerable. Okay. Flexibility can involve just passive stretching, tools like a ProStretch that are going to put that plantar surface on stretch. The gastrocsoleus complex is also very important for normal foot motion. So flexibility exercises are key. Strengthening involves, it's real tempting to talk about ankle rehab here, but with foot rehab we're talking mostly about toe activity. So having them write the alphabet in a whirlpool, picking up objects like marbles or jacks or towel scrunches, those kinds of things can be helpful in developing the intrinsics of the feet. Manual resistance exercises can also be helpful. Reestablishing neuromuscular control is really important, especially if they've been immobilized for any period of time. So doing neuromuscular control exercises using things like an unstable surface, an Airex pad, foam pad, having them exercise in sand or some other type of unsteady surface, a trampoline, a wobble board. There are a lot of different things we can do to help them reestablish neuromuscular control, because if they've been immobilized for any period of time, then even if they're ready in terms of strength and range of motion, but we haven't done these proprioceptive exercises, they're going to be more likely to get re-injured. Okay. So a lot of our rehab plans are focused more on what are called closed kinetic chain, weight-bearing type things, as opposed to open kinetic chain where they're hanging off the end of a table. So walking, jumping, running, cutting, using multiple planes, different surfaces, those are all key. That variety is absolutely essential. And then functional progressions means that we are taking them from their point of injury and then gradually returning them to things that look like what they need to do. They're functional in that it's not just training them to move a weight in a certain plane, it's training them to return to basketball or training them to return to volleyball. So we want to be thorough in our rehab. All right, well, that wraps up this week. Next week we will move on up the leg as we head into ankle, and I will see you then. So thanks a lot. Have a great day.